Treatment of peptic ulcer. Department of Pharmacology, Introduction. Peptic ulcer is a disruption of the mucosal integrity of the stomach and/or duodenum. Symptoms: burning epigastric pain exacerbated by fasting and lessened by meals. Normal peptic ulcer. Genesis of peptic ulcer. Genesis of peptic ulcer involves imbalance between the mucosal defensive mucus bicarbonate, local synthesis of prostaglandins, and damaging mechanisms, acid, pepsin, plus infection of the gastric mucosa with Helicobacter pylori. Gastric mucosal integrity is based on the balance between defensive mechanisms. Prostaglandins stimulate the secretion of mucus and bicarbonate and inhibit the secretion of acid. Mucus, alkaline, neutralizes acid. Bicarbonate ions, trapped in the mucus, create a pH gradient from 1 to 2 in the lumen to 6 to 7 at the mucosal surface. Mucus and bicarbonate form a gel-like layer protecting the gastric mucosa from acid. Mucosal blood flow. Active repair mechanisms. Aggressive factors: acid and pepsin. H. pylori infection. NSAIDs. Smoking. FRT. Pathogenesis, not really understood. Mucosal resistant theory. Defect in the mechanism which normally prevents the gastric secretion from damaging and digesting the mucosa. Acid and pepsin theory. Excessive secretion of acid, ESP, in DU. Gastrin secretion. Sensitivity of parietal cells to action of gastrin. Infection in the mucosa with BAC. H. pylori. FRT. Leaking roof hypothesis. Excessive acids in the gut lumen act upon weakened mucosa. Mucosa is weakened by bacteria, H. pylori. PU. Imbalance between mucosal defense factors and aggressive factors. Aggressive factors: acid, pepsin, smoking, H. pylori, hereditary, blood GPO, male. FRT, Helicobacter pylori. Helicobacter pylori, a gram-negative rod. Lives in the human stomach exclusively and survives in the highly acidic environment. It is helix-shaped, hence the name Helicobacter, and can literally screw itself into the stomach lining to colonize. It can remain dormant and survive for long periods. H. pylori infection can cause gastritis, peptic ulcer, predisposed to gastric cancer, etc. About 80% of people are infected with H. pylori, but only 10 to 15% develop peptic ulcer, while 60–70% of peptic ulcer patients are infected with H. pylori. FRT. Development of H. pylori-induced peptic ulcer. Produce ammonia and neutralizes acid. Penetration and adherence. Proliferate and form infection focus. Peptic ulcer. FRT, gastric mucosa. H. pylori. Physiology of acid secretion. Acid is secreted from parietal cells by a proton pump, H+/K+AT receptors for gastrin, histamine, H2, and acetylcholine, M3, are present on the parietal cell, stimulation of which leads to acid secretion. Prostaglandins decrease acid secretion. H+/K+AT, the proton pump, exchanges intraluminal K+ for intracellular H+, secreting acid. FRT. To achieve relief of pain, to heal ulcer, to prevent recurrences. Aim of therapy. To achieve relief of pain. To heal ulcer. To prevent recurrences. FRT. Principles of treatment of peptic ulcer. To decrease intragastric pH, and inhibit activation of pepsinogen, neutralization of secreted acid. Reduction of acid secretion. To enhance mucosal resistance and protect ulcer area. To eradicate H. pylori. Drugs used in the treatment of peptic ulcer. Neutralization of secreted acid, antacids. Reduction of acid secretion. Proton pump inhibitors, omeprazole. H2 receptor blockers, ranitidine. Muscarinic, M3, blockers, pirenzepine. To enhance mucosal resistance and protect ulcer area, mucosal protectives. To eradicate H. pylori, various regimens. Misoprostol, pirenzepine, ranitidine, histamine +H gastrin +++. PGE2. Ranitidine. Histamine. +. H. Gastrin. H2. M3. Adenylcyclase. CA++. ATP. CAMP. CA++. Protein kinase. Activated. Parietal cell. K+. H+. K+. Proton pump. Lumen of stomach. Omeprazole. Gastric acid. Antacid. Antacids. Antacids. Antacids are weak bases that neutralize acid and inhibit peptic activity. Magnesium and aluminium salts, hydroxide, trisilicate, bicarbonate, carbonate, neutralize acid and also adsorb pepsin. Slow onset and long action. May promote mucosal defense by Pg production. Available as OTC drugs. Sodium bicarbonate acts rapidly and relieves pain, as it can lead to systemic alkalosis and release carbon dioxide in the stomach, which may stimulate acid production. It is not advised. FRT. Antacids. Duration of action, taken on empty stomach, 30 minutes and after meal, 2 hours. Liquid formulations are more effective and fast-acting than solids. Regimen, 7 times/day. ADR. AL3 plus antacids cause constipation and Mg2 plus antacids cause osmotic diarrhea. Both together in a formulation nullify these side effects. In impaired renal function, aluminium and magnesium may accumulate, producing toxicity. By altering pH, may interfere with absorption of concurrently administered drugs. To avoid this, antacids may be taken 1 hour before or 3 hours after ingestion of other drugs. Antacids, uses and common additives. Uses: dyspepsia. Symptomatic relief in peptic ulcer. Gastroesophageal reflux disease, GERD, with alginates. Alginates form foamy layer on top of gastric contents and reduce reflux into esophagus. Simethicone decreases surface tension, thereby reduces bubble formation, added to reduce flatulence. Oxythazine, surface anesthetic. Taken hourly for severe symptom or uncontrolled reflux. Administration. Taken hourly for severe symptom or uncontrolled reflux. Taken at least 1 and 3 hours after each meal and at bedtime for uncomplicated ulcer. Should be administered as suspension form, great neutralization. Tablet should be thoroughly chewed for maximum effect. FRT. Systemic, absorbable, antacids, narco-3. Absorbed into bloodstream. Alkalosis, sodium retention in renal insufficiency, precipitates hypertension, not recommended for long-term use. Release CO2 belching, abdominal discomfort. Non-systemic, unabsorbable, antacids. Not absorbed into bloodstream. No alkalosis. All Mg2 plus salts cause diarrhea and ALO3 and CoCO3 cause constipation. FRT. Magnesium trisilicate. Relatively poor neutralizing action, react slowly with acid to form silicon dioxide that adsorbs pepsin, forms gelatinous CO2, which has demulcent action, coating on ulcer crater, and also useful for heartburn. MgO2 has prompt action, long duration, cathartic with large doses is due to osmotic effect, also used as osmotic cathartic. FRT also useful for heartburn, adsorbs and inactivates pepsin. ALO3 also useful for heartburn, adsorbs and inactivates pepsin. It also adsorbs phosphate in the intestine and are excreted in feces, decreases blood phosphate and increase resorption from bone. Untoward effects of ALO3 are constipation, phosphate deficiency, osteoporosis, osteodystrophy, encephalopathy, myopathy and renal disease. FRT drug interactions with antacids. Decrease absorption of tetracycline, ciprofloxacin due to chelation with Mg2+, Al3+. Decrease the dissolution and absorption of ketoconazole due to decreased acidity. Interfere the action of sucralfate due to decreased acidity. FRT I am prescribing low-carb diet for your diabetes, high-carb diet for your constipation, low-fat diet for your heart disease, high-fat diet for your nerves, and 1 gallon of antacid daily for your stomach ulcer. H2 receptor antagonists. Competitive blockers of histamine at H2 receptors. H2 antagonists are more effective in inhibiting nocturnal acid secretion, which depends largely on histamine, but have a modest effect on meal-stimulated acid secretion, by gastrin, Ach and histamine. Thus, they block more than 90% of nocturnal acid but only 60 to 80% of daytime acid secretion. Promote healing of duodenal and gastric ulcers. Prevent stress ulcers. Relapses are likely when the drugs are discontinued. H2 receptor antagonists. FRT 26. H2 receptor antagonists. Cimetidine is an enzyme inhibitor, says Conk, of warfarin, theophylline, phenytoin, ethanol, and no more used due to various side effects such as gynecomastia, galactorrhea, antiandrogenic and prolactin levels. Ranitidine is given twice a day or as a single nocturnal dose. Famotidine and nizatidine are given once a day. Other, for example, roxetidine, loxetidine. H2 receptor antagonists. Uses: peptic ulcer, reflux esophagitis, non-ulcer dyspepsia, bleeding in stress-related gastritis in seriously ill patients in ICU, administered for either as intermittent injections or continuous infusions. ADR, well tolerated with minimal ADR. Diarrhea, rash, hypergastrinemia, headache, myalgia, bradycardia, peptic ulcer, DU, GU, reflux esophagitis. Uses: peptic ulcer, DU, GU, reflux esophagitis, uncomplicated GERD, stress ulcer, Zollinger-Ellison syndrome, GI bleeding due to hepatic failure, pre-anesthetic medication, systemic mastocytosis, basophilic leukemia. FRT, proton pump inhibitors. FRT 30. Proton pump inhibitors, PPIs. Omeprazole, lansoprazole, pantoprazole, rabeprazole, esomeprazole. Most effective in suppressing acid production as they act on the terminal step in the acid secretory pathway and irreversibly inhibit the proton pump, H plus K plus AT plus A. Drugs of choice in peptic ulcer and have replaced H2 blockers to a large extent due to their safety and high efficacy. As they are acid-labile, the prodrugs of PPI are given as enteric-coated granules. PPI undergo activation in the parietal cells. Avoid during pregnancy and lactation. Act for more than 24 hours. Irreversible inhibition, and duration of action increases following continuous administration. cause marked inhibition of basal and stimulated acid secretion, and acid secretion resumes only after synthesis of new molecules. ADR, extremely safe, well tolerated. Abdominal pain, GI upset, pain in joints, confusion etc. Avoid during pregnancy and lactation. Causes hypergastremia, produces carcinoid tumor in rats, not reported in humans. FRT. Enzyme inhibition may decrease the metabolism of drugs like warfarin, diazepam etc. Uses. Efficacy is more if given in the morning before breakfast. Peptic ulcer. Reflux esophagitis. Component of H. pylori eradication regimens. Zollinger-Ellison syndrome, hypersecretory state caused by a gastrin-producing tumor, FRT. 34. Mucosal protective agents. Also known as cytoprotectives, they enhance the mucosal protection mechanisms and/or provide a physical barrier over the surface of the ulcer. Sucralfate. Misoprostol. Colloidal bismuth compounds, subcitrate. Carbenoxolone, ulcer healing, FRT. 36. Sucralfate. Sucralfate is a complex of aluminium hydroxide and sulfated sucrose and forms a viscous gel in acidic pH that adheres to ulcer base. Cess peptic activity. Cess local Pg synthesis, cess mucus and bicarbonate secretion. Given orally on empty stomach 1 hour before meals. As it needs acid for activation, avoid concurrent acid-suppressing agents. As effective as H2 blockers. ADR, very few, constipation, dry mouth, nausea, vomiting, cess absorption of other drugs, fluoroquinolones, digoxin etc. FRT. 38. Misoprostol. NSAID produce gastric ulceration by inhibition of Pg production in the gastric mucosa. Misoprostol is a PGE1 analog. Acts on parietal cell to reduce acid secretion. Enhance mucosal blood flow, increases mucus and bicarbonate secretion. Uses, with NSAID as prophylactic agent. ADR, diarrhea and abdominal cramps. PPI are more effective and better tolerated. Other, for example, Inprostil, Rioprostil. Colloidal bismuth compounds. Coats ulcer base, adsorbs pepsin, increases local Pg, stimulates mucus and bicarbonate secretion. Cess peptic activity. On H. pylori, bactericidal, prevents its adherence to gastric mucosa, inhibits bacterial enzymes. Use in H. pylori control regimens. ADR, not used for long periods, bismuth toxicity, blackened stools and tongue. Preparations, colloidal bismuth subcitrate etc. Carbenoxolone. It is an ulcer protective obtained from a plant. Increases production, secretion and viscosity of mucus which covers the ulcer area. ADR limits its use. Pirenzepine. Anticholinergic drug. Decreases acid production. Status, not used due to availability of better drugs. Drug regimens to eradicate H. pylori. Amoxicillin. Clarithromycin. Metronidazole. Bismuth salts. Acid suppressors. H. pylori-associated ulcers. For H. pylori-associated ulcers, there are two therapeutic goals: heal the ulcer and eradicate the organism. The most effective regimens for H. pylori eradication are combinations of 2 antibiotics and a proton pump inhibitor. Proton pump inhibitors promote eradication of H. pylori through several mechanisms: direct antimicrobial properties, minor, and, by raising intragastric pH, lowering the minimal inhibitory concentrations of antibiotics against H. pylori. The best treatment regimen consists of a 10 to 14-day regimen of triple therapy, a proton pump inhibitor twice daily, clarithromycin 500 mg twice daily, and amoxicillin 1 gram twice daily. For patients who are allergic to penicillin, Metronidazole 500 mg twice daily should be substituted for amoxicillin. After completion of triple therapy, the proton pump inhibitor should be continued once daily for a total of 4 to 6 weeks to ensure complete ulcer healing. FRT. Drugs for eradication of H. pylori. Triple therapy, 1-week regimen. Acid suppressants, antibiotics. E/L/O/P/R/ranitidine plus amoxicillin plus clarithromycin. L/O/ranitidine plus amoxicillin plus metronidazole. E/L/O/P/R/ranitidine plus clarithromycin plus metronidazole. FRT. H. pylori eradication. The most effective regimens for H. pylori eradication are combinations of 2 antibiotics plus PPI or H2 blocker for 2 weeks. Choose 2 AMA from metronidazole, 500 mg x2/d. Clarithromycin, 250 to 500 mg x2/d. Amoxicillin, 1 gram x2/d. Plus H2 blockers or PPI, twice a day, to say acid secretion. Acid suppressors to be continued for 4 to 6 weeks. FRT. Treatment of gastroesophageal reflux disease, GERD. Antacids and antacid adjuncts. H2 receptor blockers. Prokinetic metoclopramide, domperidone, cisapride. Sucralfate. PPIs.